Good morning, everyone. My name is Dr. Navapan Issariyakulkarn. I am the chairman of today's conference. Welcome to the second day of ASEAN Gastro 2021. Today, we have a lot of interesting sections with international speakers. First of all, we will start with the management of gut-brain disorder at the first section. We are pleased to have Dr. Somchai Leelakusolvong from Thailand and Dr. Sengdao Vannarath from Laos as our moderator. Please join me in welcoming Dr. Somchai Leelakusolvong and Dr. Sengdao Vannarath.
Yeah, good morning, everyone. Welcome to the second day of the ASEAN Gastro 2021. This morning, we will start with the first session, which is a gut-brain disorder session. My name is Somchai Leelakusolvong, Professor of Medicine from GI Division, Issariyakulkarn Hospital, Bangkok, Thailand. I will be a chair for this session. And today, I also have Dr. Sengdao Vannarath from Department of Gastroenterology, Mahosat Hospital, Vientiane, Lao People Democratic Republic, will be co-chair for this session. Dr. Sengdao, please.
Good morning, everyone. First of all, I very appreciate to thank you, the organizing committee, ASEAN Gastro 2021, that invite me for co-chair today with Dr. Somchai. Yeah.
Yes. Thanks, Sengdao. And today we have 4 topics in this session. Let's start with the first topic by Professor Jyhming Liou. Professor Liou graduated from National Jyhming University School of Medicine, Taiwan in 1998, and Institute of Epidemiology and Preventive Medicine, National Taiwan. Currently, he is a clinical professor, Internal Medicine College of Medicine, National Taiwan University, and also the director of the Department of Medicine, National Taiwan University Cancer Center. He is going to deliver a talk entitled The Gut-Brain Axis for Mood to Motility Disorder. Professor Jyhming Liou, please.
Dear Chairman, ladies and gentlemen, it is my great honor and pleasure to talk about the gut-brain axis from mood to motility disorders. Irritable bowel syndrome occurs in about 5% of the general population worldwide. Individuals with IBS have a 3-fold increased risk of meeting diagnostic criteria for an anxiety disorder. CNS-related precipitants in early and adult life have been reported in patients with IBS. However, about half of patients with IBS presents after an intestinal trigger. In a prospective population-based cohort study, the authors found that individuals without functional GI disorder at baseline who had anxiety were associated with increased risk of irritable bowel syndrome and functional dyspepsia 1 year after the follow-up. And conversely, they also found that patients with IBS or functional disorder who do not have psychological disorders at baseline also have increased risk of anxiety or depression 1 year after the cohorts follow-up. And interestingly, they found that in about 2/3 of those with both mood and motility disorders, an IBS diagnosis preceded the mood disorder, which indicated that maybe in 2/3 of them, the intestine disorder can be the trigger of the mood disorder. Therefore, there are bidirectional association between GI motility disorders and the mood disorders. And with the improvement in the brain image, functional MRI have detected altered brain activities in patients with irritable bowel syndrome compared to healthy controls. And in recent years, the microbiota analysis further showed that in patients with severe IBS, their gut microbiota have lower microbiome richness and have increased abundance of bacteroids. In contrast, in healthy subjects, they have higher microbiome richness and have higher abundance for Clostridium and other bacteria. And this indicated that the gut microbiome plays some role in the disease development or the severity of irritable bowel syndrome. And in patients with depression, earlier studies have also shown reduced alpha diversity and altered microbiota composition in those with depression compared to healthy controls. Therefore, there are interactions between the gut and the brain and the gut microbiota, as well as the genetic factor, dietary factors might also play some role in the gut-brain interactions. And there are some direct and indirect pathways through which the gut microbiota can modulate the gut-brain axis, including the neural pathway, which includes the vagus nerve, the ENS, and the spinal nerves, and the immune pathway, which include cytokines, and the endocrine pathway, which include cortisol and several other neurotransmitters. Here we can see that the gut microbiota can modulate the gut brain axis through the endocrine pathways, the immune pathways, and the neural pathways, the enteric nervous system, and the sympathetic or the parasympathetic nervous system. And the neural control of the GI physiology is composed of a network of intrinsic enteric neurons. Throughout the enteric nervous system, the GI smooth muscle, laminoprepia of the mucosa, and there are intrinsic innervations from the primary afferent and the autonomic fibers that connects to the spinal cord and the brain. The vagus nerve is a major bidirectional highway of the brain-gut connection. It can be influenced by microbiota-mediated modulation of endocrine, enteroendocrine and enterochromaffin cells in the gut epithelium. Serotonin receptors, the most important are UHT3 and UHT4 receptors on the vagal nerve fibers may also facilitate these messenger pathways. In mice, vagotomy can block central signaling of lactobacillus and bifidobacterium species, resulting in the disturbance of their mood-modifying effects. Another important structure is the neural pouch. It is a specialized structure on the EEC and the ECCS, which can transduce sensory signals from the intestine to the spinal cord or the vagus nerve. And then let's look at the immune mechanism for the gut microbiota or gut-brain axis. Intact immune system is important to maintain the balance between the tolerance of commensal organisms and the protection against pathogenic microbiome invasion. Intact gut barrier also prevents the inappropriate activation of immune cells and the development of systemic immune activation. And toll-like receptors and peptidoglycan mediates the immune response to microbes by acting as sensors of microbial components. This is an example. A previous study showed that the colonic nitrogic nerve numbers are reduced, and the motility are reduced in TLR4 deficient mice compared to wild-type mice. Here we can see that the neurons are reduced in the TLR4 deficient mice, and the colonic relaxation was also reduced in TLR4 deficient mice. And another study assessed the impact of TLR4 in the gut motility, and the authors found that TLR2 deficient mice exhibit abnormal contractions in their GI tract, and they showed that there are abnormal contractility in TLR2 deficient mice compared to wild-type mice, and the gastric emptying time was shorter and has faster gastric emptying, and the small bowel transition time was also shorter compared to wild-type mice. However, they have an interesting finding that after supplementation with TLR2 agonist, the GDNF. The abnormal contractility in TLR2 deficient mice could be restored. Here we can see this is the TLR2 deficient mice, and this is the wild type, and this is GDNF treated mice. And we can also see that the structure also were restored after the treatment with GDNF. And now let's look at the impact of the metabolite of gut microbiota in the gut-brain communication. The gut bacteria can produce short-chain fatty acid metabolites, including butyrate and others, that can regulate physiological intestinal functions, including the motility, secretion, and the inflammation of the GI tract. And serotonin is an important neuroendocrine transmitter that can act in neuroendocrine or paracrine fashions to impact the development and long-term functions of both the ENS and the CNS. And the neuroactive metabolites produced by the gut bacteria can modulate the brain and the behavior through a number of ways, including first, they can affect the epithelial cells to impact gut barrier function. Second, they can interact with dendritic cell and enteroendocrine cells to release GI hormones or can modulate the immune function. Serotonin is a critical regulator of the gut-brain axis signaling. Gut bacteria can produce short-chain fatty acid that directly stimulate the TPH1 to synthesize serotonin and its secretion from the intestinal ECCS. Then serotonin can interact with neurons from the ENS to modulate the GI motility. And in the CNS, the DRN and NTS are the signals action from vagus nerve, and the Raphe nucleus houses the majority of the brain's serotonin neurons. Therefore, serotonin interact with the brain through these neurons. And in summary, there are key features and functions of the brain-gut axis that we can develop new therapeutic agents targeting on these factors. And recently, there are already several antidepressants or some behavior therapy or anticholinergic agents or serotonin agonist or antagonist that can modulate the GI motility and even treat the mood disorders. And certain probiotics have also been shown to be effective in the treatment of mood and motility disorders. However, more trials are needed to prove their efficacy in the modulation of microbiota and in the effect on mood disorders. So, ladies and gentlemen, I would like to conclude that the microbiota gut-brain axis is a complex network which influences on the gut physiology and our mood. And the gut microbiota can modulate the gut-brain axis through the neural, the immune, and the endocrine pathways. Perturbation of the microbiota gut-brain axis may lead to motility and mood disorders. The microbiota gut-brain axis can be the future therapeutic targets for functional GI and mood disorders. And thank you very much for your kind attention. Thank you.
Thank you very much, Professor Liou. Yeah.
Thank you.
I think we will leave the Q&A session at the end of session. Now we move to the next speaker, Professor Sengdao, please.
Okay. Next speaker is Dr. Somchai Leelakusolvong. Let me introduce Dr. Somchai. He finished school medicine at Issariyakulkarn Hospital, University, training research fellow GI in Mayo Clinic, USA. Currently, he is professor of medicine, Faculty of Medicine, Issariyakulkarn Hospital, Mahidol University. Chief Motility Unit Disease of Gastroenterology Department of Medicine. He is also Director of Issariyakulkarn Endoscopy Center and Director of Gastroenterology and Liver Center, Issariyakulkarn Hospital, Bangkok. Please, Dr. Somchai. He will talk in the topic of the advanced in management of esophageal Dymotility. Welcome, Dr. Somchai.
Thank you, Professor Sengdao, for your introduction. And good morning, everyone. First of all, I would like to sincerely thank the organizing committee for inviting me to be one of the speakers in this symposium. My task today is entitled Advance in Management of Esophageal Dymotility. In the next 20 minutes, I will cover the following aspect. Firstly, I will tell you the criteria for diagnosing esophageal motility disorder by using the Chicago classification version 4. Secondly, to let you know that in the Chicago classification version 4, what is new in comparing with the Chicago classification version 3. And last but not least, would like to update the management of esophageal motility disorder. The Chicago classification version 1 had started to implement in 2009 and has been updated until the last version last year as version 4. I think all of you already know that this is a cartoon showing esophageal pressure topography from esophageal high resolution manometry. So, 3 crucial parameters that you need to know when you want to analyze the esophageal high resolution manometry is the first one is the IRP, which is the integrated relaxation pressure, and secondly, the DCI, which is the distal contractile integral, and the distal latency, the DL. The IRP is defined as the mean of the 4 seconds of the maximum degustative relaxation in the 4-second window beginning at the UES relaxation. In the previous version of the Chicago classification, they use a 10 second. And the DCI, which is a distal contractile integral, is a esophageal contraction which was calculated by amplitude multiplied by duration and length. The distal latency is a timing during the timing interval between upper esophageal sphincter relaxation and the CDP. So what is the CDP? The CDP is the inflection point along the 20 millimeters mercury isobaric contour, at which propagation velocity slow and demarcating peristalsis form ampullary ending. This is the cartoon that I would like to address. You again that this is the DCI, this is the DL, and this is the CDP. And the threshold for each topographic metric from different devices is not similar from one to the other, such as from Medtronic, the median IRP should not exceed than 15 millimeters mercury for Medtronic, and should not exceed than 28 millimeters mercury from the MMS. So the Chicago classification version 4 address the threshold for each system is different. Like in this table, you will see that the IRP normally from the Medtronic should not exceed than 15 millimeters mercury in the supine position. So it will be abnormal if the IRP is higher than 15 millimeters mercury, and also in the upright position if they have the value is higher than 12, is also abnormal. You can do the additional consideration, use the provocative test, and you see that for the additional consideration of the IRP, if they have an outflow obstruction, the IRP is higher than 12 millimeters mercury on the rapid drink challenge for the RDC, or the IRP exceeds than 25 millimeters on a single test meal will be abnormal. For the DCI, which is a esophageal peristalsis, normally the value of the DCI is between 450 and 8,000, and we will classify as weak when the DCI is between 100 and 450, and if is less than 100, we call it fail. And hypercontractile, it should be exist than 8,000. For the ineffective swallow, you can define weak contraction, or the failed peristalsis will be defined as a weak, as an ineffective swallow. And the contractile waveform with integrity that the ineffective swallow, the peristaltic break more than 5 centimeter peristalsis with the DCI higher than 450. The DL normally should be higher than 0.5 second. If the DL is less than 4.5 seconds, this should be considered about the spasm or the premature contraction. Should be have the DCI more than 450 as well. For the isobaric contour, you can have a pan-esophageal pressurization or the intrabolus pressure. The outflow obstruction should have the pan-esophageal pressurization more than 20 millimeters mercury or the on RDC or the single test mill. The standard protocol of the Chicago classification version 4 is shown in this slide, starting with the 10 wet swallow in supine position and going to the upright swallow. And after that, can use multiple rapid drink swallow and going to the solid swallow and also the rapid drink challenge test in the supine position and also the postprandial meal. In the red box, this is a provocative manual for testing for the Chicago classification version 4. The Chicago classification version 4 is also include the provocative test, as I already mentioned before, to add the more information or when you find an inconclusive diagnosis of the disease, starting with the multiple rapid swallow MRS or the rapid drink challenge RDC or the solid test swallow or the solid test meal and the postprandial meal and the pharmacological provocation. I will not go to all the detail of recommended provocative tests, which you can find in the recent published journal. This is a hierarchical schema of the Chicago classification. As I already mentioned before, that the protocol starting with the 10 wet swallow in the supine position and also in the upright position. If they have any abnormalities in the median IRP, this will go to the disorder of the EGJ alpha problem, which can be the achalasia type 1 or type 2 or type 3 or the EGJ alpha obstruction. The Chicago classification version 4 also add on the provocative test, as I already mentioned, and also have a wet swallow by using the MRS or the RDC. And if they have a elevated IRP, if we should go to the abnormal or the disorder of the EGJ alpha. But if they have a failed peristalsis or have an abnormality of the peristalsis, they will go to the disorder of the peristalsis, which can be the absent contractility or the distal esophageal spasm or the hypercontractile esophagus or the ineffective esophageal motility. This table demonstrated the classification and definition of a manometric disorder from Chicago version 3 and version 4 in achalasia. All types of achalasia, the definition has no change. You see that they're identical from type 1 and type 2 and type 3. But in the EGJ alpha obstruction, the Chicago version 4 address the high IRP both supine and upright position, and moreover, they should have more than 20% of the elevated intrabolus pressure and have a normal peristalsis. The symptom of dyspepsia and non-cardiac chest pain should be included. For the other group, which is the disorder of the peristalsis, is shown in this table as the absent contractility, the distal esophageal spasm, the hypercontractile esophagus, and ineffective esophageal motility. The version 4 and version 3 is identical for the absent contractility, but in the DES and hypercontractile esophagus and in IEM, they will include the clinical symptoms such as dyspepsia and all the non-cardiac chest pain in this three of the disease. So what is the key difference in Chicago classification version 4? Firstly, they have a more rigorous and expansive protocol incorporate different position and provocative manometric maneuver. They have a more stringent and refined criteria for the EGJ outflow obstruction and ineffective esophageal motility. The EGJ outflow obstruction, the distal esophageal spasm, and hypercontractile esophagus are manometric pattern of unclear clinical relevance. In the version 3, they distinguish between major and minor disorder of the peristalsis, but not in the version 4. And they also include a description of the baseline of the EGJ metric in the version 4 and define the diagnosis as a conclusive or inconclusive based on the symptoms, provocative testing, and non-high-resolution manometric testing. Finally, the Chicago classification, even version 4, is still imperfect. This is an update algorithm for management of the achalasia suggested by the ACG published last year. You will see that the management for the achalasia, if the clinical suspected of achalasia, the upper endoscopy should be commenced. And if they have a normal, the high resolution manometry or the TBE, which is a test of the barium esophagogram, and also the FIP, this is a TBE, a time barium esophagogram, or the FIP in a patient who cannot tolerate with the HRM can be performed instead of the HRM. After that, you can divide the patient into two groups. The group 1 is a type 1 or type 2 achalasia, and the second group is the type 3 achalasia. Type 1 and type 2 achalasia can have a definite therapy by using the pneumatic dilatation, or you can use the laparoscopic myotomy or the per-oral endoscopic myotomy. For the type T, is a pretty same as a type 1 and type 2, but for the definite therapy, when you use the myotomy or the POEM, you need to tailor myotomy or the tailor for the myotomy, because you can extend or not like a classic POEM for the type 1 or type 2. In a patient who unfit for the definite therapy, the Botox injection and the medication such as the smooth muscle relaxant should be considered in this group. This is an algorithm for the management of the EGJ outflow obstruction that has published recently this year. You will see that in a patient who have the clinical symptoms suspected of the EGJ outflow obstruction, we should have a elevated median IRP and both position like a supine and upright, and have a more than 20% elevated intrabolus pressure, and including the clinical symptoms, dyspepsia and non-cardiac chest pain. After that, do not forget to review the medication that can be trigger or can be cause the EGJ outflow obstruction, such as opioid medication. And after that, upper GI endoscopy should be performed, and time barium esophageal or the FIP should be considered in that cases add-on. And the CT or the EUS should be considered in some cases. In EGJ-R4 obstruction, if they have a primary or secondary, for the secondary EGJ-R4 obstruction, should be addressed at the underlying issue. For the primary, you can divide it into mild or atypical symptoms, and in another group is have a moderate or severe symptoms. About 20 to 40% of the patient in mild to or atypical symptoms, it can resolve spontaneously over the time. So in this group, observe management is just only observe the patient and looking at the symptoms that they have any improvement or not. But in a patient who have a moderate or severe symptoms, the treatment is pretty close to the management of the achalasia. For the patient who have a distal esophageal spasm, which should be have at least 20% of the premature contraction and need the DCI more than 450, and the DL should less than 4.5 seconds. If the clinical suspected of the distal esophageal, and also should have the clinical symptoms of the dysphagia or a non-cardiac chest pain. If the symptoms is considered of the DES, treatment should treatment consists of the antispasmodic or the endoscopic treatment. Moreover, consider the GERD contributing the distal esophageal spasm should be one of the cause. And in another group who have the inconclusive diagnosis of the distal esophageal spasm, additional testing like the MRS and RDC should be performed. And if the patient have a diagnosis of the distal esophageal, is possible. So the consider esophageal symptoms and additional testing in this group of the patient. So in conclusion, Mr. Chairman, ladies and gentlemen, the Chicago classification provides a standardized approach for analysis and categorization of abnormalities that has led to a significant increase in knowledge, both diagnosis and management of motility disorder. Anyway, the further refinement of the classification will be required. Moreover, no high-resolution manometry pattern or metric is absolutely sensitive or specific for esophageal motility disorder. Complementary assessment which provocative test with the new device can be useful in clarifying equivocal or inexplicable high-resolution manometry findings. Last but not least, management of the esophageal disorder is based on the physiologic studies incorporated with the clinical symptoms. Thank you for your attention. And I would like to invite all of you to join our APDW in December 2020 in Bangkok, Thailand. And please mark your calendar. Thank you.
Thank you very much, Dr. Somchai, for informative, very comprehensive talk.
Yeah, thank you, Professor Sengdao. We move to the next speaker. The next speaker actually is my best friend from Vietnam, Professor Duc T from University of Medicine and Pharmacy at Ho Chi Minh City, Vietnam. Dr. Duc is an associated professor of the gastroenterology and a vice chair of the Department of Internal Medicine, University of the Medicine and the Pharmacy at Ho Chi Minh City. He currently serves as the vice president of the Vietnam Association of Gastroenterology and the Secretary General of the Vietnam Federation of Digestive Endoscopy. He received a PhD degree in gastroenterology in 2011 at UMCH, and he has published more than 100 review and original papers in local and international journals focusing in GI and motility disorder. He is going to deliver a talk entitled Novel Management of the Functional Dyspepsia. Professor Duc, please.
Good morning. My name is Duc T. I am an associate professor of gastroenterology at the Department of Internal Medicine, University of Medicine and Pharmacy at Ho Chi Minh City, Vietnam. I would like to thank the organizer for inviting me to talk at ASEAN Gastro 2021. And my talk today will be on the management of functional dyspepsia. The agenda of my talk will include current concept of functional dyspepsia. Then I discuss about diagnostic approach, and finally the treatment strategy for functional dyspepsia. Now let's talk about the current concept of functional dyspepsia. I would like to share with you the definition according to the very recent European consensus of functional dyspepsia. As you see here that the definition is not different from what we learned in the past. And dyspepsia refers to symptom or set of symptoms that are considered to originate from gastroduodenal region. However, in order to consider as a functional one, it should be characterized by a chronic nature in the absence of organic, systematic, and metabolic conditions. The cardinal symptoms of functional dyspepsia, as you know, include early satiety, fullness, epigastric pain, and epigastric burning, and it can be categorized into EPS and PDS syndrome. When we approach to patient with dyspepsia, endoscopy is a very important investigation in order to rule out organic diseases. And I would like to share with you the prevalence of what we call clinically significant endoscopy finding in patients with dyspepsia. As you see here on the left side, in the Asian population, about 80% of endoscopy finding, as depicting in the red portion of the P chart, was normal. And it is slightly higher compared to the Western population, because in the later population, there is significantly higher proportion of reflux esophagitis. I think that it's important to note that clinically significant endoscopy finding refers to those which can explain for the dyspeptic symptom, and therefore gastritis is not included in most of the cases. But how about H. pylori gastritis? I think that according to the Kyoto consensus, H. pylori is considered now as an infectious disease, even when the patient has no symptom and no complication, such as peptic ulcer and gastric cancer. However, H. pylori does cause dyspepsia in a subset of patients. Therefore, the question is that how to, in order to see whether the two conditions have a causal relationship or not, we need to eradicate the infection and to follow the resolution of the symptoms. If the symptoms do not improve, or if there is only some improvement after eradication and then the symptom recur within 6 to 12 months, the patient should be considered as having functional dyspepsia besides H. pylori infection. However, in daily practice, I think that it may not be necessary to follow patients for such a long time to define the situation, because the number need to treat is only about 1/10. That means 90% of patients with H. pylori gastritis and dyspepsia actually has functional dyspepsia. Now let's talk about the diagnostic approach for patients with functional dyspepsia. And I would like to share with you one of the collaboration work in our region, which shows that the majority of patients with gastric cancer in our region have been diagnosed in the very late stage, and we definitely don't want to miss these patients. The prevalence of gastric cancer and H. pylori infection vary significantly across countries in Southeast Asia. In order to avoid missing the cancer, alarm features have been considered as very important findings that require prompt investigation, including endoscopy. However, according to systematic review, alarm feature had limited value in predicting upper GI cancer. As you see here that the sensitivity varies significantly across original study from 0 to 83%, and therefore age cutoff should be considered as an additional factor to select patient for prompt endoscopy. According to the ACG guideline in 2017, the age cutoff in the US is about 60 years. And according to a more recent paper in Lancet, the age cutoff is recommended of about 55 years. However, Asian patients with gastric cancer tend to be much younger. And therefore, in the recent guideline, we see a lower age threshold for patients in Asia. In Thailand, the recent guideline recommended the age cutoff should be set at 50 years in Thai people. In Vietnam, we have a much higher prevalence of early onset gastric cancer. And this study shows that about 1/6 of gastric cancer at our hospital were diagnosed at the age of less than 40 years. When we look at the alarm feature, the sensitivity was only 60% in early onset and up to 80% in the late onset gastric cancer group. At this just a small study, we tried to conduct another with larger scale study. And recently we finished collecting data of a large scale study, aiming to determine the age cutoff, which assure a low missing rate of gastrointestinal cancer, and also to assess the use of prompt endoscopy to detect upper gastrointestinal cancer. In this study, out of about 500,000 patient outpatient who underwent endoscopy, there were 2,200 patients with gastric cancer. This slide shows that if we choose the age cutoff of 45 years, about 1/6 of cases of gastric cancer and upper GI cancer in Vietnamese would be missed. And therefore, we believe that a lower threshold should be more appropriate in Vietnamese. This study also showed that using the age cutoff of 40s, the use of endoscopy is about 1 per 1,000 procedure. So I think that in each population, the age cutoff should be decided differently according to the prevalence of early onset gastric cancer in that population. Now I would like to discuss about the treatment. There are several kinds of food which were reported to associate with dyspeptic symptoms in functional dyspepsia, including fatty food, milk, alcohol, coffee, etc. However, few RCT have been shown the efficacy of diet intervention. How about efficacy of medical management? I think that the highest evidence came from study with H. pylori eradication. And we have a lower level of evidence with PPI, anti-H2, and prokinetics. According to Rome 4, the first-line treatment should be considered based on the predominant symptom of the patient. And if the patient has EPS of the predominant symptoms, anti-secretory drugs should be considered. PPI have been shown to be effective in functional dyspepsia with an NNT of 11, regardless of dose and prescribed period. In this systematic review, it could not be able to compare PPI with prokinetics due to potential bias of the original studies. How to use PPI appropriately in patients with functional dyspepsia is also an important issue, so as not to avoid unnecessary costs for the patient and also to avoid potentially long-term side effects of PPI. In patient with functional dyspepsia, PPI should be used in a standard dose in 4 to 8 weeks. And in those who fail to respond after 8 weeks, a double dose regimen is not more effective and should not be considered. And in those with good response, we need to reevaluate patients and consider to stop the treatment before 6 to 12 months in order to avoid potential risk of long-term PPIs. In patients with PDS is predominant syndrome, broadkinetics should be considered. And I would like to share with you a recent meta-analysis from Professor Rapat and her team, which show that broadkinetics was effective in all subgroups of patients with functional dyspepsia. Interestingly, it showed that broadkinetics were more effective in patients with an NNT of 5 compared to Caucasian patients with an NNT of about 10. However, this study did not see any significant difference regarding efficacy of different broadkinetics in patients with functional dyspepsia. In patients who fail all of the above treatments, antidepressants should be considered. The term is now changed to another term, neuromodulators, as we aim to modulate the gut-brain acid activity and not to deal with the purpose of treatment depression in many cases of functional dyspepsia. This is a very interesting paper from Rome 4. It showed that if the patient have anxiety, depression, and phobic features as predominant symptoms, then NSRI are the first choice. However, if pain is predominant, then TCA is the first choice. And in those who could not tolerate the side effect of TCA, then NRI should be considered as an alternative in patients. And in patients with an early anxiety, nausea or vomiting, and weight loss and disturbed sleep, so tetracycline depression should be considered as the first choice. This slide summarizes the consensus of the recent European Society on Functional Dyspepsia in 2020. And the high level of agreement is represented in the green circle, while the yellow is for lower agreement and the orange circle for much lower agreement. And as you can see here that the highest level of consensus is for H. pylori eradication and for PPI use. And we have a lower agreement for using diet intervention or DCA, and a much lower agreement for prokinetics, other neuromodulator and hypotherapy, hypotherapy and CBT, etc. Finally, I would like to share an important landmark cohort study, which shows that the highest number of patients with gastric cancer are those with what's so-called in the past non-ulcer dyspepsia and now functional dyspepsia. I think that is a clinically important point in the long-term management of functional dyspepsia in patients who also have H. pylori infection, even after eradication. Because in the real-life practice, we treat the patient not just the symptoms or the syndrome. And therefore, I think that whenever the patient has an indication for endoscopy, opportunity screening and stratifying the level of risk for developing gastric cancer should be always considered. And the local approach to stratify the risk of the patient should be considered based on the local resources in your country. And I also have discussed this in detail in a recent paper in World Journal of Gastroenterology published in 2019. For conclusion, I would like to mention that functional dyspepsia is a common GI disorder in daily practice, which often mistermed as gastritis. Alarm features are not sensitivity for upper GI malignancy, and age cutoff should be used as a chunk factor, taking into account that it may be different across population basing on the prevalence of early onset gastric cancer in that population. For the management, H. pylori eradication should be always considered, and the classification of FD could be helped to decide the first choice as well as the appropriate treatment based on the predominant syndrome. And finally, the risk level of gastric cancer should be always considered for long-term management of patient with functional dyspepsia and also have H. pylori infection, even after the patient have been successfully eradicated, to stratify the risk for gastric cancer and in order to have the patient to receive the appropriate surveillance program. With that, I would like to end my talk. Thank you very much for your attention.
Thank you very much, Professor Duc, for your excellent talk. And we will move to the last speaker.
Okay.
Professor Sengdao, please.
The last speaker is Dr. Navapan Issariyakulkarn on the topic of new medication for GI motility disorder. Dr. Navapan, she finished medical school at Mahidol University, training research assistant at Neurogastroenterology Group, Wingate Institute, Queen Mary University, London. Currently, she is gastroenterologist at Gastroenterology Unit, Department of Medicine, Thammasat University. Please, Dr. Navapan.
Good morning, everyone. First of all, I would like to thank the ASEAN Gastro 2021 organizer for inviting me here today. Let me introduce myself. I am Dr. Navapan Issariyakulkarn from Thammasat University Hospital, Thailand. The topic of my presentation today is new medications for GI motility disorder. This is my reference today. I would like to divide my talk into 4 parts. The red line, I would like to talk about the drug for gastroparesis. The yellow line, I would like to talk about the novel analgesic drug. The blue line, I would like to talk about drug modulate by salt. And the purple line, I would like to talk about the drug for IBS. Let's start with gastroparesis. There are 4 medicines I would like to introduce. The first one is tradipitant. That is the tachykinine or neurokinin 1 receptor antagonist. Substance P acts on the NK1 receptor and plays a key role within central immunity circuitry along serotonin. Substance P binds the NK1 receptor at the gastric neuromuscular junction and has a functional interplay between acetylcholine and NK1 receptor system to stimulate smooth muscle contraction. Before knowing the action of this drug, there is a NK1 receptor antagonist that was approved by US FDA in 2008. That is apipitant. The indication of apipitant is the drug for prevent nausea, vomiting during the chemotherapy. Apipitant inhibits effect of substance P within central immunity circuitry or throughout an effect of NK1 receptor on workout reference. The clinical trial of apipitant that was approved by US FDA in last year. The subject is gastroparesis patient with diabetic or idiopathic. Apipitant 75 milligram was given to this patient for 4 weeks. After 4 weeks, there was evaluated the patient with questionnaire of gastroparesis cardinal symptom index daily. The result is more than 1 point improvement of GCSI score was seen. And the secondary outcome is high rate of nausea response, increased percent of nausea vomiting free day, and larger improvement in total GCSI score. Palpitation was also has been reported in COVID-19 pneumonia, motion sickness, and atopic dermatitis. The next one is Leelakusolvong. That is the ghrelin receptor agonist. Ghrelin receptor are located at the motor nucleus of vagus and in myenteric neuron throughout GI tract. Leelakusolvong accelerates gastric emptying time in both type 1 and type 2 diabetic, as well as stimulate postprandial and motility in healthy. The clinical trial of Leelakusolvong, that is the subcutaneous injection, was introduced in diabetic type 1 and type 2 with poor hemoglobin A1C. The duration is 12 weeks. The result is 25% reduction in vomiting frequency compared with baseline, but not significant compared with placebo. And all 4 GI symptoms of diabetic gastroparesis significantly reduced in all 3 doses. However, dose-dependent worsening of gastric control was not. So the phase 3 clinical trial of Leelakusolvong were terminated. Move to Felsitrac. I apologize if I had a wrong pronunciation. This is the highly selective and potent 5-HT4 receptor agonist. There was a study after IV administration in healthy volunteer and in treatment of enteric feeding intolerant in critical care patients. 5-HT4 demonstrate phonetic activity in the short term. The clinical trial of 5-HT4 is IV infusion for 3 days in a row. The subject is gastroparesis patient. The result is Felsitrac significant accelerate gastric emptying T-half, colonic filling at 6 hours, and 10% small bowel transit time at all 3 doses, without clinical significant finding from clinical laboratory, vital sign, or ECG. The next one is Thammasat. That is the novel peripheral selective D2D3 dopamine receptor antagonist with limited brain penetrate and low affinity to gene potassium channel. This drug was developed for reduce the adverse effect of dopamine receptor agonist. The study is a phase 2A randomized placebo-controlled trial with 3 doses of Thammasat compared with placebo. Thammasat was given to the patient twice a day. The first part is evaluate the efficacy of 3 Thammasat doses, and the second part is to evaluate the effect of food on pharmacokinetic comparing with metoclopramine. The result was shown. No effect on gastric emptying was demonstrated with Thammasat, but volume to fullness was significantly in 25 milligrams of Thammasat, and no significant in the benefits of GCSI DD scoring. This drug was shown no adverse effect with cardiovascular or central nervous system comparing with placebo. Now, move to novel visual analgesic. The first group is smart mu opioid receptor ligands. Mu opioid receptor agonists induce analgesic by activate G protein mediated pathway throughout the recruitment of beta-arrestin. With mediated receptor desensitization and internalization leading to the activity of mu opioid receptor in the lysosome. Beta-arrestin activation induce respiratory distress and inhibit gastrointestinal motility. This smart opioid receptor ligand was developed for minimize beta-arrestin 2 for reduced adverse reaction. The first group of smart opioid receptor ligand is bias ligand. That is the favor one signal pathway downstream of the opioid receptor over another. The first G protein bias ligand which was approved by FDA in last year is oliceridine. Which was indication of treatment is moderate to severe pain for in adults whom alternative treatment other than opioid. There are many bias ligands that has been developed. For example, the study of PZM21 in primates and the study of SR1701A in rats were shown the effect of analgesic. The other smart opioid receptor ligand is NF-EPP. That is furolinate fentanyl molecule that is actively selective in the acidic environment, such as in site of inflammation. NF-EPP inhibits visceral motor response to colorectal distension without decreased defecation or respiratory distress. The study was conducted in mice. In contrast to the bias ligand, NF-EPP activates the opioid G protein copper cell receptor signal pathway, so that accurately recruits beta-arrestin and evokes mu opioid endocytosis that prefer in acidic condition. That's what shows superior pain relief in preclinical model. Next to other smart mu opioid receptor ligand is carbaminoid 2 receptor or CRB agonist. CRB mainly expressed in immune cell and peripheral tissue, especially in colon and enteric nervous system. Increased CRB expression has been demonstrated in preclinical model of GI inflammation and gut tissue from human with IBD or IBS. Olodidap, oral peripheral acting visceral analgesic and highly selective agonist of CRB was developed. Olodidap is an oral tablet. The clinical trial of olodidap, that is an oral tablet, was given in patients with IBS-D or IBS-C according to room 4, 3 times a day. This study was a phase 2 multicenter randomized double-blind placebo control. Unfortunately, in moderate to severe pain as baseline, there was only 1.6 point pain reduction score compared with placebo. So, olodidap in phase 3 trial was terminated. Next to the modulating by salt effect for bowel dysfunction, ilobisibag is a novel inhibitor of apical sodium-dependent bile acid transporter or aerial bile acid transporter inhibitor. 15% of IBS-C reduce the level of bile acid and level of deoxycholic acid in fecal sample. So if lower level of excrete of bile acid into feces may correlate with slower chronic transit time. Itopositbac increase secretory bile acid in the colon, as measured by stool bile acid content, without significant change of fecal microbiota. Itopositbac had a two-phase study. Oh no, sorry, two-part study. Part one is about the efficacy of this drug, which was give itopositbac 10 mg per day. Part 2 is for evaluate the safety of drug, which was given 5 to 15 mg per day. The subject of both drugs is functional constipation or IBS-C in Japan. This phase 3 study, part 1 is an RCT for 2 weeks. The part 2 is the open label single arm for 52 weeks. The result of part 1 was show significant improvement of the frequency of spontaneous bowel movement per week during the first week of treatment. Part 2 was shown nearly half of patients had adverse drug reaction. Most common is diarrhea. One patient reported developed inguinal hernia. That was reported as moderate adverse reaction. Next is farnesyl X receptor agonist. Farnesyl X receptor agonist, or FXR, stimulate the synthesis and the subsequent release of fibroblast growth factor 19 from epithelial cell and inhibit biosynthesis by hepatocytes. So FXR reduce intraluminal concentration of bile acid in the colon. That might improve diarrhea. FXR mainly developed for non-alcoholic fatty liver disease or cholestatic liver disease, but can reduce biosynthesis by hepatocytes. That may also prove beneficial for patients with functional diarrhea associated by acid diarrhea. Obicolic acid, that is the FXX receptor agonist approved for PBC, is the steroid FXR agonist. The other is tobiphenol, that is non-bile acid FXR or non-steroidal FXR agonist that improves stool index and slow ascending colon emptying with bile acid diarrhea. The clinical high of tobiphenol in primary bile acid diarrhea show a significant increase in ascending colon half emptying time. The last one is the drug for IBS, that is the Thammasat, which was approved by US FDA in 2019. Thammasat is a selective inhibitor of sodium hydrogen exchanger or NHE3, inhibit of NH3 on apical surface of enterocytes, reduce sodium absorption from intestinal and colon, lead to increased water secretion into intestinal lumen and accelerate gut transit time. Thammasat inhibit active absorption of phosphate in intestine too. The clinical trial of Thammasat, that is 50 mg, was given BID in IBS-C patients. The phase 3 multicenter randomized double-blind showed the result. Thammasat can reduce abdominal symptoms and global symptoms of IBS, but drug discontinuation in Thammasat more than placebo significantly. Diarrhea is most common adverse reaction. Thammasat significantly reduce elevate of serum phosphate in hemodialytic patients with hyperphosphatemia too. In conclusion, about new medication for GI motility. In gastroparesis, selective NK1 receptor agonist, Tatipican, was approved by FDA in last year. Leelakusolvong, ghrelin receptor agonist, the phase 3 clinical trial were terminated. Phase 3 track the least selective 5-HT4 receptor agonist show a good result. Test P. Robin, dopamine D2, D3 receptor antagonist, may need more research. Novel analgesic drug. Smart U opioid receptor ligand. Both bias ligand and NF-EPP are in preclinical models which are very good results, whereas cannabinoid 2 receptor agonist olodinab was terminated in phase 3 clinical trial. Modulating by salt effect for bowel dysfunction. Itolizumab, ileal bile acid transport inhibitor, was approved in Japan and Thailand. Farnesyl X receptor agonist, tropiphenol, show a good result. About IBS, tinapanol was approved by US FDA in 2019. Second point, many novel medications with new mechanism has been developed for a better outcome for functional and motility gastrointestinal dysfunctions. The efficacy and safety of these drugs has been observed in more clinical trials. Thank you for your attention.
Thank you very much. I think now we come to the Q&A session. Yeah, we have about 15 minutes left. Okay. Let's start with the first question from the chat. I would like to ask Professor Liou that and I have two questions. The first question is what is the major mood disorder that affect motility disorder the most? And second question is the role of anti-anxiety and antidepressant in motility disorder. Professor Liou, please.
Okay. Thank you very much for the two important questions. Now I answer the first question. Anxiety and depression are the major mood disorders that can affect the motility of GI. But in our GI clinic, anxiety disorder is more common than those with depression, because maybe patients with depression, they will go directly to a psychiatrist. But both disorders can affect the GI disorder. And the second question, the role of anti-anxiety and antidepressant in motility disorder. And my answer is in cases with mild or mild to moderate symptoms, anti-anxiety or antidepressant are usually not necessary initially. However, in patients with moderate to severe symptoms or persistent symptoms, anti-anxiety and antidepressant such as TCA, SSRI may be helpful in relieving pain and other symptoms. So I think only patients with moderate to severe symptoms or persistent symptoms, or they also have combination symptoms, diagnostic of depressant can be more helpful from antidepressant. Thank you.
Thank you, Professor Liou. But Professor Liou, from my knowledge that when we review the literature of the functional GI disorder, I think we quite often see the result of the antidepressant more than the anti-anxiety drugs, such as a tricyclic antidepressant or even the SSRI is more compelling with the anti-anxiety. Do you have any hint or any suggestion for using in the clinical practice for a patient who have a functional GI disorder who have a moderate to severe? Because I think Duc already mentioned some neuromodulator drugs in the clinical trial for the functional dyspepsia, but I think for me, personally, I often use the neuromodulator drug for the antidepressant more than the anti-anxiety drugs.
Yeah,
What do you
I
think?
very agree with your viewpoint. I very agree.
Yeah, okay. Yeah. Maybe second question, Professor Sengdao, please.
For the floor, for Dr. Duc,
Yeah.
how we can treat functional dyspepsia overlap with GERD or IBS? Please.
Okay. Thank you very much for this important, clinically important question. And if we have time, I would like also to ask the faculty for other experience from other countries. In my opinion, I think that we should focus on the most common symptoms. And it's important to consider, I would consider 3 points. The first point is that some drug act on both disorders. For example, that PPI, when we use PPI, we can use with efficacy for functional dyspepsia, especially the epigastric pain syndrome. And it also has a very good efficacy on patients with reflux symptom as well. And we also have some prokinetics which show that some benefits for patients with heartburn, for example, etopride or mozapride. So for patients with postprandial distress syndrome and coexist reflux disease, I think that prokinetics may have some benefit. And the second point for daily practice is that we should also consider the side effects of the drugs that we use for patients with overlap syndrome. And some side effects could be good, and some side effects could be considered and not and should be avoided. For example, that for patients with postprandial distress syndrome, the patient has symptoms like indigestion. So I think that mozapride and I think that a 5-HT4 agonist can help the patient who also have IBS with constipation. And with that side effect, we can help and reduce the number of drugs we use to treat the patient with constipation. And for example, modulation, neuromodulator, for example, PCA has the common side effect as constipation, and it could be considered in when we use antidepressant for patients with diarrhea predominant irritable bowel syndrome. And for the patient with I think that for the patient with constipation predominant IBS, it should be avoided. And besides that, SSRI has a very common side effect as the diarrhea, and it could be used for patients with constipation predominant IBS. It should be avoided in patients with diarrhea predominant IBS. And the third, and I think that the most important part is that when we have the patient with overlap syndrome, psychiatric aspect is very important because it's a very in my daily practice, I think that it's a very important point in order to solve the problem of the patient, and it should be always considered in our practice. So if we have time, I would like to ask the other member of the faculty to share the experience. Thank you.
Thank you very much.
Duc, I think I do agree with your idea, and the first concern that I always use in my clinical practice is what is the major predominant complaint of the patient? Because if you have overlap GERD with the functional dyspepsia with the IBS. So what is the main problem that brings the patient to see the doctor or the physician? Because if we counteract with the major predominant symptoms and the symptom disappear and the less of the symptom we will cope after that. And as you already mentioned that the majority of the drugs can have a two effect or have the same effect like a functional dyspepsia and GERD. When you use the PPI, it would be a benefit for both disease, and also the side effect should be considered in that medication for using in a patient who have an overlapping syndrome. And last but not least, for the functional dyspepsia that who have a long history and also have an overlapping functional dyspepsia, the psychiatric problem is one of the major problem, and you have to have a good physician relationship which we can continue and can explore the hidden agenda of the patient when they come to see you. Yeah. Any add-on information from Professor Liou and Professor Navapan or not for this question? If you know, I go to the third questions. We still have 5 minutes left. Asking Dr. Navapan, some motility drug might cause a cardiovascular side effect. How you can select drug in motility this disease with safety? Dr. Navapan, please.
Thank you for the question. As we know, the old generation of prokinetic drugs, such as cystapide, may be caused the QT prolonged. In my opinion, I prefer use the new generation of prokinetic drugs, especially in the cardiovascular patients. But if we have only the old generation, I prefer to monitor the patients with ECG occasionally.
But Dr. Navapan, you always monitor the EKG personally. To be honest, I didn't do that because I think for the patient who have the 5-3 or 5-4 even agonist or antagonist, I think we see very few cases of the cardiovascular effect, and we don't know exactly yet that this is a cause from the drug or not. But anyway, like a partial 5-4 agonist like a tecasilot and aloceton is not available in Thailand because the not only the GI side effect but also the cardio side effect also causing that this is a limited prescribed drug and did not available in Thailand at this moment. And also the old drug like a cystapide, which is have a serotonin group as well. And another like Mosapine, which is just only have one study showing with the fectanine have a torsadepone in that situation, but it's very few cases. So I normally I will, if I prescribe the drug that can cause the cardiotoxicity or the cardiac arrhythmia. Oh, by the way, the D2 receptor antagonist such as domperidone is mentioned in the EMA that should not use in the elderly and it should not use exist than 2 weeks and in the high doses because they have a retrospective study that three study that more than 1 million people that can cause a cardiotoxicity. But anyway, we should, when we want to use a long-term period, we have to talk to the patient. Any additional comment? Professor Liou, Professor Duc, and Professor Sengdao.
No.
Okay.
Okay. I think it's the last one question for Dr. Somchai
Okay.
from the floor. How to select the treatment in achalasia, poem, pneumatic dilatation, or Botox injection?
Yeah, very excellent questions. Normally, for the Botox and for the medication, I will preserve for the patient who have unfit to the Botox, unfit to the pneumatic dilatation or the poem or the hair myotomy. If the patient fit to this three procedure for the type 1 and type 2, I will go to any like pneumatic dilatation or poem or helermyotomy. If they have a type T achalasia, I will go to poem firstly and consider about the myotomy in the second priority. For the type 1 and type 2, if the patient is a male and younger age group, this is a group that not good response to the esophageal balloon dilatation, I will talk to the patient and maybe suggest to perform the poem and helermyotomy instead of the endoscopic dilatation. Yeah.
Yes.
I think we have only 30 seconds left. So before closing the session, I would like to sincerely thank Professor Sengdao, my co-chair, Professor Liou from Taiwan, Professor Duc from Vietnam, Professor Navapan from Thammasat University, and Professor Somchai from Issariyakulkarn Hospital, Bangkok, Thailand, for giving our vulnerable session for the BenCat interactive for functional GI disorder this session, and I would like to use this opportunity to call this session closed. Thank you very much.
Thank you very much.
Thank you very much.
Bye.